Good evening, everyone, and welcome to First Aid AMC. This is Dr. Mavish. I'm one of the mentors for First Aid AMC. Hoping everyone will be well. If you can please confirm you guys can hear me clearly. Okay, thank you, guys. Thank you. So I think we shall start our session for tonight. Okay, I think my internet is a bit wobbly tonight. So if anytime you guys feel like there's a disruption in the internet, just type in the chat box, okay? All right. Let's start tonight's session. Okay, so this is you, like a doctor after night shift from ED, went to the bar. He found his colleagues there, and some are having illicit drug. They have to go to hospital for duty in 2 hours or 2 hours later. What will you do? You will inform APRA, which is a regulating medical body in Australia. You will leave and said nothing. You will report to ED, or you will tell directly to those of your colleagues. Okay, yes, I think most of you guessed it right. So, what you can do in that case, because they are your colleagues, so it's better that you can just go and directly ask them whatever your concerns are. And if in case they are not understanding, and if you are still concerned that they will not follow your approvals or whatever you said to them, then it's a better understanding that maybe you can go towards your senior. So, whatever will be senior in the STEM, it may be your registrar or supervisor or the department head, whatever is next, then you can inform. But first of all, never confront, but you can just politely tell to your colleague that what is right, and they have to go for duty, and they just need to just go from there, things like that. So it's always better with your colleague. But with the senior, I think we have discussed earlier, it's a different thing. You cannot confront your senior no matter what. You need to just directly go towards your supervisor about their misdeed or whatever they're doing wrong. Okay, understand, guys? So this was it. Okay, next question. So this is an old man in aged care. He doesn't sleep at night, walk outside whole night, a sort of absconder. We can say absconder. So what to give? Temazepam or sertraline? We just have two answers here. Yes, the question is not very much given in detail. I agree. But whatever information is there, and I also agree that temazepam is addictive, very true. But we can give them at least for a short period of time because we don't have the understanding that the patient might have some depressive symptoms why they were admitted. So we don't know the history or the background. At the moment, whatever is given there, you can still give a trial of temazepam because temazepam is a short acting less shorter half life, so it can dissolve easily and come back patient come back from the addictive symptoms easily, so they cannot get as addictive as to the longer acting benzodiazepine. So you can give a trial of temazepam just to make them sleep at night. Now things would have been different if the patient would be in the delirious state, so we don't have any information about the delirium at the moment. But our patient is just, you can say, an absconding patient which can just roam around in the ward and then They are not sleeping. Maybe something is happening with them. So we're not sure about the history. So that's why we can just give a trial of the temazepam just to calm them down, and it helps them to sleep as well. So antidepressants we cannot try unless the patient have depressive symptoms approved. That's why. And also we don't have the complete stem. That's why it is a safer option. I think I have put information about this one. Maybe you can have a look here. What I do is maybe just reduce the windows. Okay, if you can have a look here, maybe scroll down a bit. So this is for the insomnia management, and that apply to for inpatients as well. So if you can have a look of the insomnia, it's just insomnia, okay? We don't know about any mental health issues in this patient, right? So just taking insomnia in the regard. Now, obviously, insomnia, the CBT is a first line of therapy. So we offer first line of therapy to all our patients. For example, if first line of therapy is not acting, and obviously that patient is in hospital, so they require a bit more, you can have a trial after the behavioral therapy for the pharmacological management of the insomnia as benzos. You can try that, a short acting. So you can have a look here with a shorter half-life, which will be zolpidem, temazepam, and zopicon. So most commonly we use temazepam here. So you can have a trial about that, but obviously for a short period of time. So we don't want the patient to be addictive on that drug. And yeah, I think most commonly we can use them. And we have a RCT trial again for the benzodiazepines for the sleep therapy or the sleep medication. So we can try that. And that's it. Okay, everyone on the same page? Okay, correct. Right. So moving on to the next question. Uh, I think I have another reference as well. Let me have a look. What is that? All right, yeah. So this reference, I think, put it to show you about the behaviorally disturbed patients. So those patients who are in hospital, but obviously, regardless of the condition, they are delirious. So for the delirious patient, the management is a bit different. Obviously, we can sometimes have to mentally restrain them. We have to provide them the delirium management. So I think that's why I put this reference here. So you can read it if you want regarding it. So if delirious patient is present, we can provide them with the IM benzos. Obviously, we cannot give them the oral benzos. So to restrain them, this is the management for a delirious patient with the behavioral issues. So you can have a read here. Okay. Now next question. So as a medical, so this is what the recaller has given the information. Okay, I've not included any of my words in it. This says as a medical doctor going to discharge. So you are a doctor going to discharge a schizophrenic patient. Now gets called by a patient's brother. The brother said that the patient told them that they will do suicide after returning to home. So, as a doctor, what will you do? You will discharge the patient anyway, you will not discharge them, or you will assess the suicidal ideation from your patient. Okay, so everyone agrees that we have to assess a patient for the suicidal ideation. The duty of care to you gives you the indication that they are your patient. So she is your patient, no matter who calls you, their partner, their parent, their brother, whoever gives you a call, and maybe they can show the concerns, but you cannot rely on the concerns unless you see your patient yourself. So she is your patient. If you think that the patient is at risk of suicide ideation or risk of suicide, then you won't discharge. But first of all, you will check your patient. You will not trust anyone except your patient if they are mentally capable, obviously. Okay. So you will assess your patient and then you would decide. I think this guideline serves a purpose better. If you guys have time, maybe, no, this is for something different. Sorry, this is not belonging here. I think I put it from somewhere else. No. So for this one, I think I need to attach a guideline. I will attach a guideline, ethical guideline I have somewhere. I'll attach it so you can have a better understanding of those cases. Okay, next question. So this is a 4-year-old boy. He cannot climb the stairs but can walk. Growth charts are okay. Jerks are absent. So most probably they're talking about the knee jerks. Mother has also a weakness of leg. Investigations required for that patient or that child. Nerve conduction study, MRI or CT scan. Okay, so we have a mixed answers here. So CT scan all out. We don't agree on that. Okay, the confusion remains between the nerve conduction and the MRI. So we can do both. Okay, depends on the symptom. So first of all, we need to understand that the knee jerks is commonly a nerve injury. So a nerve involvement, L3, L4 nerve roots. So L3, L4 is a solely nerve root, and we have to understand that nerve. Now you can do MRI and you can do nerve conduction study as well. But if you have a look on this question that the child can walk, growth charts are also okay. So something to concern, but the growth charts are okay. So that's why we understand that there is not something extensively involving the CNS. So MRI in that case would be less required as compared to the nerve conduction. Okay, so nerve conduction studies, we can understand and we can study nerve root L3, L4, which is providing the knee jerk. And then if we require the extensive study or more study, then we can definitely do MRI, but obviously CT scan not in that case. So the answer would be nerve conduction here. And I may have one reference here regarding this question, so give you more understanding. So peripheral neuropathies. Now, if we have peripheral neuropathies here, maybe just go on to the point of discussion and just leave other things here. So stay with me. I'm just reading and taking you guys to what we need to discuss here. Okay, so once you understand the etiology of the peripheral neuropathy, then you have to discuss about the diagnosis and the management. So we have investigations here. Okay, so once you have discussed with the parent and you have decided that what you need to do, you want to do the investigation. So neurophysiological studies, including the nerve conduction studies and electromyographies may be required. Electromyographies are required when obviously you see the power and power loss and the muscle wasting. But at the moment, we don't have any clue about this in the patient's history. So if you want to have a look here, right, so this was for the single nerve, right? If you come down here and have a look for more complex cases of peripheral neuropathy, there may be a need for more detailed investigation, including MRIs or ultrasonography and nerve biopsy. So MRIs or ultrasonography or nerve biopsy comes under complex studies where the sign and symptoms are more complex and there's a complex history. Okay, but you don't have any history and the growth charts are okay. So we just have the information about growth chart of this patient, which is okay. They say it's okay. So I'm not sure about what was it? So at the moment, nerve conduction study is only thing, or maybe the first line thing you can do, but you can do MRI later on, I would say. So start from the nerve conduction and then you can do later on. So that because it says the mother has also the weakness of leg, so we are not sure, maybe something familial is happening sometimes. So start with the first line and then move on to the next line. Yes, Dr. Neetu. So maybe some confusion regarding it. I'm not sure what the recaller was trying to say. Maybe some familial condition was there. So that's why they cannot, maybe some nerve conduction studies will be required to exclude the weakness of the familial cause of the illness. That's why we are starting with the first line investigation. Diagnosis here would be the peripheral neuropathy, doctor. Okay. So peripheral neuropathy, Duchenne had the myopathy as well. So we have a peripheral neuropathy more likely. We don't have any muscular involvement here. If the muscles are involved, then maybe it's a Duchenne's muscular dystrophy. So we are not sure about it at the moment unless we have a full history of the patient. Okay, so nerve conduction for this one, and we did the reference as well. Moving on to the next question. So you would see more of the ethical questions in tonight's presentation because October has more of the ethical questions. So have a look here. Mother of 6-day-old baby only sleeps. So mother only sleeps 2 to 3 hours per day. Father is alcoholic and don't take care. What to do? What you will advise to mother? A good sleep hygiene tricks. Call husband or ask community nurse to visit home. All right. So the father is alcoholic, so we take this mother as a single mother because father is here but not responding and not communicating and even not participating in baby's health or the wife's health. So we take as a single mother, and for a single mother we do have services, so we can obviously ask them for the good sleep hygiene. But at the moment she wants your help, she's coming for the help because she is not having a good sleep. She has just a 6-day-old baby for which she needs the sleep. So she can go into the depression. And that's why you need to help her. And to help her, you need to ask the community services to visit their home. There are services here in Australia, and we can ask the nurses to help the newborn mother. Even it's not required at the moment, even if the dad is here, even if the mother is not the here the families, even the mothers are very young, they give time to babies, birth to babies. So you can just ask the community services to help the moms. They can go to their home, bath the baby, help the mother with the baby. So at least they can go once in a week and help the young moms or even the single moms. So this is an option here. We can ask the community nurses to visit their home and they can look after the baby while the mother can just do their works and maybe they can have some rest. The idea behind this question is she is asking help from you. So the only help in this answer would be you can just ask the community nurse. Yes, good hygiene, the good sleep hygiene trick you can ask her, but obviously the husband is not helping. So how can she maintain a good sleep hygiene if nobody is there to look after her baby? Okay, okay. I think this would be the quick one as well. So, you have a patient who cannot do eversion and dorsiflexion. What commonly nerve involvement will be there? Common peroneal, tibial, or L4? Okay, that's a repeat as well. Yeah, that's fine. But try to understand that these question doesn't come like a single liner. Okay, so there will be the big stem, and then after the big stem, they will just ask you that the patient cannot do this, and you have to understand that patient, and then you have to answer your question. Okay, so everyone agrees on the common peroneal. I think we have a picture here. So common peroneal nerve gives the innervation to the muscle which is tibialis anterior, and this is responsible for the dorsiflexion. So if the patient cannot dorsiflex their foot, the condition is called foot drop. Okay, guys. Next question. So this is 60 plus age lady presented with shoulder pain, knee pain, and forearm erythema. ESR is high. What is your diagnosis? Dermatomyositis, fibromyalgia, or polymyositis? Okay. So your patient is having shoulder pain, knee pain. So throughout the body, they're having pain in the main girdles. They have a pain in the knee, they have a pain in the shoulder, and they have erythema. So this erythema is making a confusion here. But if you can, I'll show you the reference in a bit. So if you consider about the ESR, there is some inflammation going on. There's some inflammation going on, and with polymyositis and dermatomyositis is most likely involving the muscles. Okay, so when you have a condition which is involving the girdles or the bones, it's most likely a condition which is inflammatory. And fibromyalgia is a condition that involves the girdles and the bones. With the myositis, as the name suggests, is a myositis involving muscles. Yes, it's inflammation, but involving the muscles. So the answer here would be fibromyalgia. And we will just understand in a bit about more in this reference. I think I have one or two references, yes. So we can discuss maybe a bit more. Let's have a look on this one first. Okay, so this is about the fibromyalgia and polymyalgia. So we are not discussing polymyalgia at the moment, okay? Just discussing the fibromyalgia. I'll take you here. Fibromyalgia, inflammatory, is not an inflammatory condition by sensory processing in the central nervous system. So patients are sensitive to pain and other pleasant sensations. So you will have typically tender points throughout the body. So what happens with the patient is that who have a fibromyalgia, they have a tendency to receive the pain throughout their body, everywhere, and especially in the girdles. It's different from the polymyalgia rheumatica, which we all know about the polymyalgia rheumatica, and that is an autoimmune disease. So this was one bit, and I wanted to show you another reference here. I think this is for the dermatomyositis. Yeah, myositis. Okay, have a look here. Okay, myalgia, connective tissue disorder. one thing. Then if you want to look here more, so widespread musculoskeletal pain, fatigue, stiffness, and hyperalgesia. Hyperalgesia means that they have a propensity to disper more pain rather than the normal individuals. So they feel more pain. And then if you want to come more down here, yes, I'm just coming to the point, Dr. Shabir. Just give me a minute. I'm just scrolling down to give you a more understanding. Okay, let me have a look if I have more references. One, two, and no. So these two maybe. We have a look on this one again. The information was there. Just stay with me. I'm just looking. Okay. So fibromyalgia, if it says the myalgia, so connective tissue disorder, we all understand about the connective tissue disorder. But if the condition comes as a myositis, that means the inflammation of the muscle. So if there's a, so I'm telling you about the difference first of all, right? So myositis means fatigue is not involved because there's a muscular pain. Myalgia is there because the muscular pain, and hyperalgia is not involved because it's just the muscular pain. So patient's tendency towards the pain is increased in the fibromyalgia, for example, in a connective tissue disorder. And then we have a more of this, the erythema. So if you understand about this question, more about, they're especially talking about this erythema as well. So this is again a condition which is can involving the fibromyalgia, but not happening in the dermatomyositis and polymyositis. So dermato and poly more or less a similar thing because involving the muscles, but this is involving the dermis as well or the skin, but this is involving the multiple muscles. That's why it's called polymyositis. Yes, we do have some skin manifestations in fibromyalgia. I think I have forgotten to put it here, but let me give me a minute. I maybe just share with you guys now. Fibromyalgia. Okay, I think in Healthline, I saw one reference. Maybe I can just share on my screen just now. Give me a minute. Yeah, it's there. It's not common. Yes, it's not common, but you can have the rash with the fibromyalgia. So if you can have a look on this information here. So skin symptoms may be there, like a rash. So maybe the recaller is trying to give us the information about the erythema as rash. I'm not sure, but it's not a common symptom. With the fibromyalgia, skin rash is not a common symptom, and ESR is always non-specific, guys. So if there is, for example, if the patient is obese, so we are not sure the 60 plus lady might be obese, okay? So if there's a obesity, again, ESR is increased. So ESR is not a specific for either the fibromyalgia, even for the polymyositis. You have to look for another autoantibodies as well for the fibromyalgia even. If I can just show you this reference again, the first one, you can see the more of the specific antibodies they look for the fibromyalgia patient. Have a look on this one. So with the rheumatoid anti-nuclear, anti-citrullinated, so they are all non-specific antibodies. Same with the ESR. If the patient is obese, the ESR can also increase. That doesn't mean that it is responsible, the fibromyalgia is not there. So maybe the recaller is missing some questions, some clues here for us, but it's definitely not dermatomyositis and polymyositis. The condition is more likely going towards fibromyalgia because they're coming with the girdle pain. The more symptomatic, the more the patient is coming with the pain, while myositis is the muscular pain. So if I try to give you the more information about the myositis and myalgia, it's more likely a muscular pain and the pain coming from the bone. So if I'm having a pain in my shoulder and my knee, if you guys can understand, you guys are having a muscular pain or you guys are having a pain from your bone. It's like that. Make sense? Yes, CK is raised because there's inflammation. That's why the CK is raised. But I think we all understand that CK is not always specific. ESR is not always specific. Can happen with SLE. It can happen because it's the connective tissue disorder, Dr. Nahir. So it can happen with SLE as well. Okay, I think much discussion was done. What I do is maybe next time, if this question or sometime, because I understand that you guys are confused about now polymyositis and dermatomyositis. So if sometime this question comes up, maybe I can just give you more information about the polymyositis with more of the references. So the confusion will be clear next time. Okay, this is again a vague question, very less information, but let's see how we can decipher. So this patient is on dialysis, and after dialysis, hand and forearm become cold. What is the problem? Thrombosis in the inflow of the fistula, thrombosis in the outflow of fistula, or the fistula failure? Okay, so if we all understand about the fistula creation and dialysis, so when the patient is going towards the end stage renal kidney disease or end stage renal disease, we do perform the dialysis and we create the fistula. So why we create the fistula? We create the surgically communication between the artery and the vein because they need the clearance. Their kidneys are not working. Now the thing is, when the patient is on the dialysis and afterwards their fistula is there, but the patient comes after the hand and forearm cold, that means the blood supply is lost. The fistula you have created, the blood supply is not there anymore. So what is the problem here? The syndrome. So the answer for this is outflow of the fistula. I explained to you why it's outflow and not inflow. It was a bit confusing for me as well, but see, have a look on this one. So this is actually a case study. And so this patient was created a fistula for their renal artery insufficiency. And if you want to have a look on this thrombosis here, so there's certain problems with the fistulas, and one of the problem is thrombosis. Okay, so thrombosis is a problem associated with the vascular access, and AV fistula thrombosis is likely to occur secondary to the venous outflow stenosis. So when the when the blood is coming from the arteries to the vein, there's an obstruction somewhere, and the thrombosis formation is somewhere in the outflow. So that's why it is a complication called for the fistula. I think there's a name for that as well. I'm not recalling the name on top of my head. They call some syndrome. I'll check online maybe for that. But there's some syndrome which is called the blockade of the fistula due to the thrombosis, and it is in the outflow over the venous side, not towards the arterial side. And fistula thrombosis can occur in following the dialysis, and the patient who are receiving the fistula may be compressed to attain the hemostasis. So when the fistula thrombosis is there, in the examination, you can have an absence of the bruit and the thrill. And the management option again will be that you have to remove that embolus or remove the thrombosis by the surgical thrombectomy. Steele syndrome. That's right, Dr. Froza. Yeah, thank you. So there's a Steele syndrome. And the Steele syndrome is something which is called thrombosis in the fistula. So fistula is they created on their own because they wanted to have a shunting. And then in the fistula, sometimes the complications happens. So this is all the complications of the fistula, including the infection, stenosis, thrombosis, aneurysms in the fistula. And we are discussing this thrombosis. Okay, from here to here, we have just discussed. Yes, because the blood supply was lost, Dr. Soch. That's why. The fistula they created for the dialysis was not patent. The thrombosis was created in the venous area of the fistula or towards the outside of the fistula. So blood is coming fine, but towards the outflow, the thrombus was obstructing the blood. But this is a fistula, doctor. Okay, this is a fistula. This is not a arterial occlusion. This is a fistula which we created for the dialysis. It can create a confusion. It can create an infection, Dr. Maliha. That's why I showed you earlier that we have some what they call as side effects of those fistula or complications of those fistula. So one of them could be infection. It could be the stenosis. It could be the thrombosis. So these are all the side effects of the fistula, maybe. No, it towards the venous side. It's towards the outflow of where the fistula is created, outward side. The outflow of the fistula is blocked. Okay. Right. Similar question, but a different etiology here. So this patient is coming on post-op day 3, one leg cold, no dorsalis pedis. So maybe they're asking for the management here. What will you do? You will do thrombolysis or you will do embolectomy. Okay, so when this much information is present, the confusion arises. Now the information we just have to understand is the day 3 post-op and one leg is cold. so no dorsalis pedis pulse, and we have a loss of blood supply here. The ultimately what you have to do is you have to remove the thrombus, whatever is coming. So you have to remove that. And thrombolysis, with the thrombolysis, you don't have enough time. If the pulse is lost, you have to immediately do the embolectomy to revive the blood supply. Otherwise, you will lose the leg, or maybe you have almost lost the leg. We are not sure because you don't have the pulse at the moment. Okay. So you have to remove that emboli. And for the emboli removal, if you want to opt for thrombolysis, it will take time. You don't have that much time. So you have to refer immediately to the vascular surgeon. And for that, they will do the emergency embolectomy if they can revive the leg. Otherwise, when the dorsalis pulse, pedis pulse is not there, maybe the leg is not revivable. I'm not sure here what is happening in the background because the extremities is cooled. Maybe you can revive it, but you can at least try with the embolectomy, and urgent vascular referral is needed for those type of patients. So if you have more information in the question, then you can try maybe thrombolysis. I'm not sure if more of the information would be there, but that much information just give us the clue that we need to have the emergency embolectomy because we have to survive or we have to revive the leg. The patient would be having the heparin. So patient would be having the anticoagulants, obviously, post-op. The patient is post-op, but still after having the heparin or anticoagulants, they have developed the embolysis. They have developed the thrombosis and they need something. They need the help to remove the thrombus. That means that their anticoagulant therapy is not working. So we have to treat the patient as an emergency vascular surgery and we have to refer them to the vascular department. So removal of the thrombus is needed for the embolectomy. Yeah, given the condition of the patient, Dr. Shabir, so it's a golden rule, you're right. But if the more information would be present, it's more easier to understand. But see, whatever information we have, embolectomy for you guys makes more sense. I understand because thrombosis, if the patient is, the leg is at risk, you don't feel the pulse, how can you subscribe, how can you prescribe them any antithrombotic therapy if you want to revive the leg ASAP? So it is not possible for the antithrombolytic therapy to just act on that, that extent, that's quick extent. So this was for DVT. I think post-op DVT, I put it here. Sorry, I'm just trying to get the information we need to discuss. Otherwise, it's a bit reference. So no need to just read all of that. It's an ischemia, doctor. Okay, it's an ischemia, but I have put the reference for DVT here. That's why I'm seeing if I have put anything regarding the ischemia here. Maybe not relevant to our discussion, this reference. So I maybe just delete the reference. Maybe this reference. Okay, yeah, this is the one maybe we can discuss. This is again the case study. So I found this reference helpful. That is, I think I put it here. Have a look on this reference. Maybe we can just have much of the information here. Okay, so this patient has the hip surgery, and after the hip surgery, they were found to have ischemia. And what was done here that you can see. So just after coming from the surgery, they were fine, but afterwards their pulses were lost. So 25 hour after surgery, the leg become cold and dorsalis pedis tibial popliteal femoral artery were absent. So Doppler scan showed the occlusion of the right femoral artery, and that vascular surgery was consulted immediately to perform emergency right femoral thromboembolectomy and then prophylactic fasciotomy, obviously. So in that case study, I understand, or maybe we can understand that the patient post-op, even after 25 hours of surgery, they had a limb ischemia, acute limb ischemia, and then embolectomy or emergency embolectomy was performed. So they didn't rely on the thrombosis here because the limb salvage was most important factor here. They want to salvage the limb ASAP. And this fasciotomy, I think we are not concerned at the moment. So I just wanted to show you about this case. This is what I just got from the internet. No, in such case, Dr. Sidra, so they ask for the best management, right? So if the arterial pulse is low, on the bedside they have Doppler. So you don't need to send the patient to any lab or somewhere. You can just do a bedside Doppler. And then if you understand that you don't feel the pulse here, you don't listen to the pulse in Doppler, then obviously the leg is cold, the extremities are cold, then this is the indication that you need to send the patient to vascular surgery. Because CTA takes time. You don't have that much time. You can just confirm with the Doppler. If you don't feel the pulse, if you don't listen to the pulse, then it's time the patient to send to the surgery. Okay. Next question. So this question says that barium solo should be given, maybe in the question, and Zenker's diverticulum was diagnosed. They're asking the management for this patient. Is it endoscopic staple or is it laryngoscopy? Okay, just two answers and a bit of confusion because laryngoscopy and endoscopic staple, both of them obviously they're not they're different treatments for different things. But again, only answer we can give here is endoscopic stable. But yes, an endoscopic staple is not done these days as well. So we do with the laser these days, endoscopic staple, because obviously it's a surgery and takes time to heal. So they don't do the staple these days. The thing is done by laser these days, but I don't know why they don't have any option here. So the only option we have is endoscopic staple. So whatever we have is the answer here. So lasers have been used for the upper endoscopy to resect the diverticulum. So if you understand it's a diverticulum on the barium solo, then staples are not used these days. So overall, lasers have been shown to have obviously fewer recurrences and further improvement in the symptoms compared to the use of the staplers, which were used before, but not these days. Then open surgery is more invasive and requires obviously the longer hospitalizations and doesn't provide the rapid relief of symptoms and the low rate of recurrences. Then again, we have the complications of surgery like the nerve palsies, bleeding, perforations to esophagus, and the trauma to the oral cavity. I think I've attached one reference here. Have a look on this one. So we understand what is Zinker diverticulum. So just moving down. Now evaluation. Okay, so they're done with the evaluation, the barium solo, the treatment. So only symptomatic lesions need the treatment. So not all the lesions need the treatment. The lesions less than 2 centimeters rarely require any treatment. Only lesions who are associated with achalasia, botulinum toxin may help relieve the symptoms of dysphagia. For all other, larger, then surgery is indicated. So if you can have a look here, it can be treated by an open procedure or an endoscopic approach. In surgery, the process is to divide the cricopharyngeus muscle because we want to relieve the pressure on the pouch of the diverticulum. And now this paragraph I have copied here from here. Have a look. This paragraph we have discussed already. So this is again the pros and the cons with the myotomy and with the endoscopic diverticulectomy with the stapler. And this is the staging. So we are not concerned about staging at the moment. Yes, Dr. Fezia, they do the laser. So resection is done with the laser rather than the knife. So the laser is used. Previously, they used to do the staples. So previously, when we were doing the study, we used to learn about the staples with the diverticulum. But nowadays, surgery with the laser is preferable because obviously we learn about the side effects and the pros and the cons. So I don't understand maybe this option. There are three options missing. So I don't know maybe if the recaller is missing the options because the recaller is like us, the student. Okay. So they maybe understand only those two options and they're not able to understand the other three options. So what I'm trying to say is that if you have all five options, and if there's the option for the laser, which is more preferable these days, do that. So just try to understand the topic more rather than just taking the options. And because this recaller maybe like us, it's the student. So maybe they just understand whatever they understood at that time. Okay, guys, clear? I think it's time for us to take a break for 10 minutes and then we can just meet after 10 minutes, guys. So have some break and I see you in 10 minutes time. Okay, thank you. Yeah, hello, doctors. Everyone back? Is everyone back? Okay, thank you. So we can just start. Okay, while on the break, I was just looking on one of the references. I might not be able to attach the reference here because it's from up to date. So it's a paid reference. I'm not sure if you guys have the subscription, but maybe we can share the reference now so we can just discuss a bit about the fibromyalgia and the myositis. We were just confused. Is it okay? Okay, so maybe I can just share my screen with you guys. Let me just exit this one. Where did it go? Okay, this one. Are you guys able to see my screen? Okay, have a look on this one. If you want, I can attach the reference, but again, if maybe somebody has the subscription or somebody has not, so I just don't want to create the confusion for that. But have a look here. So this fibromyalgia is a differential for the myopathies like the myositis, all the dermato and polymyositis. So it can be distinguished from inflammatory myositis and the metabolic myopathies by features evident on the history and examination as well as the lab testing. Although myalgia and fatigue are prominent in both fibromyalgia and disorders of the muscles themselves, myositis and myopathies cause muscle weakness. Okay, so muscle weakness and muscle fatigue but are not associated with diffuse pain. So this is I was trying to make you guys understand that this is the myositis are the muscle fatigue and muscle pain, but not the diffuse pain for the joint. So if you remember our questions, the recaller has mentioned about the knee pain and the shoulder pain. This is why it make a confusion here that it is a pain which was diffused throughout the body girdles, especially knee, hip, shoulder, but not a muscle pain or muscle fatigue. So patients with fibromyalgia do not have significant muscle weakness other than the related to pain or disuse. So this is the most important differentiating factor. And I think some doctor mentioned about the muscle enzymes, CK, yes, which is also valid. So FM people do have normal muscle enzyme test or they don't have this non-specific histopathological findings. So muscle biopsies are not performed in the fibromyalgia people. But if you are considering as a myopathy, then you can do the muscle studies like the biopsies or the CKs you can do, like the muscle enzymes. Okay, Dr. Shabir, you can download the PDF. I can. I'm not sure. If I would be able to download, then definitely I can share in the messenger for you guys. Okay. Outflow and the inflow. Okay. Okay. Then again, I have to check for up to date. If up to date has the picture, definitely they would have. Then I can just share with you guys. Okay. All right, we can just move on to the next question. If the confusion has cleared about the muscle and the fibromyalgia, so let's come to the next question. The patient comes with the lower abdominal pain, no history of dysuria or frequency, 20 ml of urine residual in the bladder, so post void. No stone was found. On examination, multiple blister-like lesions in the vulva or bilateral inguinal lymph nodes were enlarged. What is the diagnosis here? Is it urosepsis or is it lymphogranuloma venerum? Okay. So only two options, and obviously we have a big history, but two options here. And this Eurosepsis is nothing but just the UTI. Okay, we don't use the Eurosepsis term anymore here. I don't know. Maybe those of you who have worked in the UK or works in UK, maybe they can use the term more Eurosepsis, but it's nothing just like the urinary tract infection, what we called it here. But this lymphogranuloma venereum is the UTI. It's a rare UTI, but it manifests as the same thing, like a multiple blisters. And again, this is not very much common in females, but this obviously this question represents a female. It's more common in males or the gays. I can show you maybe the STI reference. The answer for this one is lymphogranuloma venereum. And maybe the STI guideline, we can have a look on this one. Okay, so we have a look on the clinical presentation. So starts with the ulcer, and then the lymph node swelling and discharge can happen. And if it spreads like a tertiary condition, then it can create proctitis, fistulas, strictures, scarring, whatsoever. And then the complications. So long-term complications are rarely seen. Obviously, it's a rare STI as well. That's why we don't usually often hear about this commonly. Now, if we understand about the diagnosis here, so diagnosis is done obviously by swab. So if it starts, as I said, it starts with the ulcer. So we can do the swab, and then we can just send for the PCR. And then investigations. So commonly present in the men who have sex with men, MSM, and high rate of the co-infection with syphilis, hepatitis, HIVs, everything. Proctoscopy is performed. Read if its proctoscopic level reached to up to the proctitis, then if you can understand about the proctoscopy, perform the proctoscopy, and then you can see the ulcers. So it's more likely involving the back passage, rectum. That's why we understand about the proctoscopy. Less common in the females. I don't know about the history properly. We don't have enough history, but it's less common in female. But if it's there around the vulva. Starts with the ulcer, and sometimes the ulcer goes up, but usually they go back. Then we have management. So management is similarly for any STI. We start with the doxycycline. And that's it. I think we don't need to maybe do more about this one. But remember, it's more likely involving the MSM. So in the female, it's less common. So if the condition is more presenting and more going towards the male to male, then it's more likely lymphogranuloma venereum. Okay, moving on to the next question. So this is a 16-year-old girl presents to your clinic. Her period started at 14 years, and from the beginning, she have had the irregular cycles with 5 to 6 monthly intervals, with heavy bleeding, hirsutism, acne, everything is present. Okay, which risk of which cancer? So they mean to say that if the girl is presenting with those signs and symptoms, they are of risk of which cancer? Is it breast cancer, cervical cancer, or endometrial cancer? So the sign and symptoms are presenting for the PCOS, as we all understand, and PCOS are at a more risk of the development of endometrial cancer later in their life. So research says that we can have a look on this literature. So with the gynecological cancers in women with PCOS, the most likely risk of involvement is it's the endometrial cancer. And maybe I can take you here. Okay, so when they did the study, so the study has been proven that apart from all the gynecological cancer, endometrial cancer is most commonly involving the ladies who have the PCOS in their early life. This starts later in the life, not very early. So if we can just understand about this here. So obesity, nulliparity, age more than 50 years. So obviously it shows up later in the life, not early in the life, maybe postmenopausal stage around 50 or maybe around the menopausal stage. Infertility, hypertension, diabetes. So they should have all the comorbidities, obviously, for the PCOS, and then they have an age factor, which is more than 50. So at that age, when they studied, endometrial cancer was most important cancer and most common cancer, which relates to the ladies who presented with PCOS in their earlier ages. Then we have the ovarian cancer as well and the breast cancer. So all gynecological cancer. But if you ask about the most commonest one, then it is the endometrial cancer. Okay, moving on to the next question. So this is a 78-year-old female living in the aged care, recently became forgetful, taking one old man frequently to his bedroom, kissing and hugging. What to do? You will inform the family members. You will do sex education to the lady. You will assess the relationship for both of them, or you will assess her mental status, or you will inform the aged care authorities. No, unfortunately, we cannot let them alone, doctor. So you are a doctor, okay? Now aged care people rely on you. In your position, what you would do? Obviously, if she is forgetful and recently the changes in the memory has been noticed, you cannot leave it like that. If it was it's a different story, then we cannot just do something and we can just let them be. But one, she is in aged care, is in your care. Second, she is forgetful. So anything can happen. At the moment, what you can do is you can assess her mental status in your capacity. This is the only thing you can do. After assessing her mental status, and if you feel like that forgetfulness thing is a thing which can be considered, or which is a thing which she's having, and because of that she's having those things, then you can inform the aged care authorities or your higher authorities. But in your position and your capacity, you can assess her mental status because you know her history. Okay. So you will assess her mental status and we'll go from there. Next question. I think this has been done previously with different questions, but have a look. So, pregnant women bring her 6-year-old child got chickenpox. So, child got chickenpox. Okay, she never had chickenpox before. What you would do? You would do vaccine. You would give them the IgG, or you would take the serology from her. Yeah, I can see somebody mention it's a repeat. Maybe it's a repeat, but doctor, it presents in different ways. So this chickenpox question come in many different ways. So this is a thing where the child just has the chickenpox, mother doesn't have any symptoms. One question is the mom also has symptoms while she's in pregnancy. So many types of question comes up. If you guys want to discuss it more, we can discuss, or maybe we can just do the answer and move on. What do you guys want? Okay, so the majority says discuss, so we'll just discuss. Okay, what happens here is, as the fellow doctor mentioned about the question is repeat. Yes, so the previous question I'm aware of, comes up like the pregnant lady comes to your clinic and she has sign and symptoms because she has an encounter with someone in the park or their friend's place and that child has chickenpox. Now she is concerned that she's pregnant. Now what should she do? Okay, this is a similar question here, but this is her own child and who has chickenpox. One question comes up like that she has symptoms and she is in, for example, her first trimester of pregnancy, what you should do. So if I want to discuss with the detail, first of all, you have to check the patient's immunizations history. You have to ask the patient that if they have the childhood in their, if they have the chickenpox in their childhood or not. If the patient doesn't recall, you have to ask about the vaccine. Obviously, they won't recall that. I don't know if I've been vaccinated, if I had the chickenpox earlier, I'm not sure. And the next thing is she's pregnant. Okay, now you want to save the baby. If she's pregnant and she's not sure about her vaccination history or her immunization history or previous encounter with the chickenpox, the most important thing you want to do is you can check for the serology. What we want to do here is serology. Number one. Okay, so for this patient, we will do serology. The question comes up, many question comes up like that the patient is having the rashes or patient is symptomatic. She has the encounter with someone who has had the chickenpox and now the patient comes to you with symptoms. In that case, would you do the serology or you would do the IgG first? You would do the IgG first because the patient has the symptoms and then you want to provide the immunization to the patient. Okay, so this things comes many different ways. Now we are not discussing with the vaccine at the moment because we all know that vaccine is contraindicated. We cannot give the MMR in the pregnancy, live vaccine. So we are not discussing about the vaccine. But the way the question comes up, we need to understand that this patient doesn't have any symptoms and she doesn't recall her immunization history. So in that case, you would start with the serology. You don't want to give IgG at the moment. But if the patient is symptomatic, you want to start the treatment. Understand? Okay, no problem. And this reference is really nice. This is from South Australian Guidelines. Again, those who are with us in this course and the last one, you guys know that we take the reference from this one. So this is a very good reference. Give it a read, guys. It's quite confusing if I just read it with you now. That's why I just simplified and discuss in my own words. But if you go and read this one, you may be better understanding of what we were discussing in the class. Give it a read. It's very good reference. And just it will just clarify your concerns. This one, okay? So it has many presentations, like during the pregnancy, I think during the postpartum period as well. So the question comes up from anywhere. Okay, there's a time period for the immunoglobulin. And then when can you start the antiviral? I show you here. I think I saw it somewhere here. See, so the history of the previous chickenpox, no action required. Okay, that means she has developed her own immunity. You don't need to do anything. Now, see, if she's not certain about the history of the chickenpox or she's not certain about the immunization, you have to obtain the serology to check her immunity if practicable. And then immunoglobulin required should be given within 96 hours. Okay, so if you want to give her immunoglobulin, it should be within 96 hours. In that window, you have to give the immunoglobulins. Within the 96 hours from the exposure, you can give the all seronegative mothers IgG. Now, what happens if more than 96 hours are there? More than 96 hours are there, then you can start the antiviral, which is going to be oral acyclovir or valacyclovir. Usually give valacyclovir here during pregnancy, but it can be either of them. Okay, so this is the answer for antiviral. So IgG should be strictly within 96-hour window, and then afterwards you can give them the antiviral. Okay, shingles, we are not discussing. Sorry, doctor. So when the shingles question come up, we will sure discuss about the shingles. Okay, maybe you guys get confused or your peers get confused if I just start discussing about the shingles from nowhere. I hope you understand. Okay, guys, clear? We move on to the next question. So now see, this is a motor vehicle accident, fracture of the tibia and the fibula, lacerated deep wound. Tetanus vaccine dose was 6 years ago. What to do? You would give the TT vaccine now, you would not give the TT, or you would give the TT and the immunoglobulin. Okay, this is again a repeat. Sure. So should we discuss this one or just move on, doctors? You guys want to discuss? Okay, I don't mind. But if it's a repeat, I don't want to waste the time again for you guys. Maybe we can just do the next question meanwhile. Hmm. We can discuss this a bit. Okay, that's fine. No problem. Okay, so what reference I have? It's a very maybe understandable reference because it's from, I think I took it from New South Wales Health Guideline. So we can have a look on this one. Okay, so this tetanus vaccine last dose was 6 years ago and it's a deep lacerated wound. So it's not a minor wound. Okay, so we understand that. To my understanding, we need to give the TT only for him now. Why? Because, have a look on this one. Okay, so disregard this one because it requires the 3 doses. So we just understand that a patient has got 3 doses. Okay, now you have to see the time since the last dose, and then the type of the wound. And then if you want to give the vaccine or the immunoglobulin. Okay, so just check these four columns and then we can discuss it more. So clean minor wounds, all other wounds, clean minor wounds, all other wounds. So a patient has 6 years ago. He had the vaccination 6 years ago. So it should come here somewhere, not a clean minor wound, but a deep wound. Okay. So between 5 to 10 years, and then a patient comes with all other wounds, and then you have to give the vaccine, yes, but no immunoglobulin unless the person has immunodeficiency. So a patient comes somewhere here because he has a vaccine 6 years back. So between 5 to 10, he comes under other wounds because the wound was deep laceration. We understand. If you want to give vaccine or no, yes, you have to give vaccine and no immunoglobulin because your patient is not immunodeficient as what we don't see from the history. If your patient is immunodeficient, then you can give the toxoid immunoglobulin as well, but at the moment only DPT vaccine is required. It is different for all the stages of the wound, you can see here. So just maybe don't give yourself confused here. We just remain on this question here, that a patient stays somewhere here, that he has a deep lacerated wound and he required the immunization but not immunoglobulin at the moment. If the wound was clear, then even vaccine was not required. Okay, if you don't have the vaccines, you don't, and the patient give you no history of the vaccines or they don't remember the vaccine, obviously you will give the vaccine and immunoglobulin both. Same like any other thing, that because if the patient don't have the understanding of their vaccines or they don't have the vaccines, you want to give vaccines. So here, less than 3 doses or uncertain. So not sure if they have the doses or not sure if have the 3 doses. Any other wound, even clean or minor, you have to give the vaccine. Yeah, it's in the record. You're right. Everything is in the record, but sometimes you are coming in a rural practice and the sometimes you don't have the record for the patient. And on the spot, or for example, you have the patient on the bed on the roadside. The patient on the roadside, only the paramedics and the doctors are there, and you're asking the patient that did you have the vaccine, and the patient doesn't remember. So at that time, what you want to do? Usually in the clinic, when the patient is in the clinic, do you have the record in yourself? Okay. So at the moment, you don't need the IgG unless your patient is having immunodeficiency. usually on the internet, we have all of the TT guidelines. They're all confusing, even confusing for myself as well. I always make confuse myself that what should we do. But this guideline was really good and very easy to understand. Okay. This question, I think similar sort of question we did, but this is a different question. Okay. So left eye vision loss, the patient comes with left eye vision loss suddenly and gain within a few hours. Left carotid stenosis 60%, right side is 30%. What will be the management? Carotid and arterectomy, carotid embolization, or stenting? Okay, different reasoning for this one. See, this is the Averroes fugax, yes. And then we have one eye which is 60% and one eye which is 30%. And then the eye which is 60%, they had a sudden vision loss and they gained within few hours. What will be the management? So I'm not sure, first of all, that asking for the management of left eye or right eye, because right eye is 30% and right eye is non-symptomatic, but left eye is symptomatic and it is 60%. So if you guys remember, maybe I think I did with you guys the RCGP guideline or the topic we did. So if the patient is symptomatic, no matter how much the percentage, you have to do the end arterectomy. Okay, transient ischemic attack. But if the patient is non-symptomatic and even they have the stenosis, you can do the medical management as well. So, not sure you're asking about the right side or left side. If it's right side, they're asking about the right side. We can do the medical management, but medical management is not here. So, understandably, they're asking about the left side, which is they gain the loss of sudden loss of vision and they regained back, which is TIA, and it is 60%, but the patient is symptomatic. So the answer would be end arterectomy here. I'll take you maybe to this reference again. So you might have a recall of this one. We did, I think, together. So maybe we go towards the point we want to discuss. See, so this is a symptomatic carotid artery stenosis. Okay, so symptomatic refers to the neurological ischemia with a significant hemodynamically significant stenosis. So stenosis of more than 60, more than 50, which our patient has. So he has 60. And then the the patient has the symptoms. So the symptoms are a sudden onset of sensory or motor impairment or the vision loss or the dysphagia, whatever symptoms are there. What you have to do is in that case that you have to do the end arterectomy. I think in the later paragraph, we have the arterectomy. I'll show you. But this is the asymptomatic carotid artery stenosis. So the patient has the stenosis. We don't know how much, but doesn't cause any symptoms to the patient. So management, if you want to go towards the management of the symptomatic, so urgently referred to the vascular department. And the gold standard treatment for the symptomatic is carotid end arterectomy, CEA, because you want to minimize the percentage of the stroke here. And if you want to have a look on the asymptomatic, see here, the commencement of best medical therapy is a principle for the management of the asymptomatic. So what will be the medical therapy? You want to start with the antiplatelet, you want to start with the statins if their cholesterol is high, and obviously the cardiovascular risk modifications. So this is only for the asymptomatic stenosis. Doesn't matter about the percentage here. And as I said earlier, if the percentage is low, but your patient is symptomatic, you want to do the carotid end arterectomy as a gold standard treatment. So this point maybe is worth looking here. You can have a look on these points as well. Whatever we discussed, they have just summarized very well here. No, you don't do the CAA in asymptomatic patient, doctor. So with the asymptomatic, we start with the medical therapy. You do only the surgical therapy or CEA in the patients who have shown the symptoms. Even the stenosis is very less than 50, but they are showing the symptoms. You want to send them for endarterectomy. Okay, so this was it. And next question. Okay, who sent this one? Dr. Huang Pan. Yes, thank you. Thank you. Yes, I think we pretty much discussed that. And anything, maybe anything more, uh, other doctors can maybe benefit from your message here. Okay, see, the ECG is showing the VT, ventricular tachycardia. During the management, the pulse falls to 40. What to do? Adenosine, DC cardioversion, atropine, or amiodarone? Hmm, page is not given. Sorry. Sorry, I think my internet went off. Are you guys able to see my screen now? Yes. Okay. So, yes. So, first of all, the question is not clear. We only have a pulse here. We don't have the BP here. So, how we can proceed with the DC cardioversion here? So that most of you understand with the ACLS algorithm that if we have the pulseless rhythm, we can do the DC cardioversion or non-shockable rhythm. But obviously, we don't have the whole of the information here. We just have the pulse. So we maybe stick with the DC cardioversion here. If I do have the understanding of more about the blood pressure and other sort of things, then maybe we can have a trial for the adenosine. I'm not sure what the whole question was, but it's better to understand about the ACLS whole. So easier to understand. Sometimes the question comes up from the ACLS algorithm. I think last time we did the question, similar, very similar question about the shock. So this is again the DC cardioversion, but all of us understand about the blood pressure thing in the DC cardioversion. So maybe we can, the algorithm of ACLS, if you want to discuss, maybe we can discuss after this class when once we finish the question because we don't have enough time left. It's almost 10:16. So if we go in the detail of the again ACLS is maybe taking more of the time for the next questions. Okay. So this patient with the past history of MI plays autonomy for non-DR, not non-DR, but other. So he plays autonomy that something else, but not DNR. Hospitalized for pneumonia, denies taking antibiotics. His daughter is insisting to give him antibiotics. You try to make him convince, but still he is not agreeing. What will be next? DNR is do not resuscitate. So this patient has placed the orders for something else, but not DNR. That's what the recaller says. So it is not DNR, okay? It is something else. But he placed the order for autonomy that do not treat me. Yes, we have to acknowledge his decision, whatever the decision he has made previously regarding his autonomy. So he has said that he doesn't want anything. That's why we can just acknowledge his concerns. Doesn't matter, he's sick, the family wants the treatment, doesn't matter. But if he has placed some orders before his medical treatment, then we have to acknowledge and respect their decision, which is honor his decision. So in that case, there is no problem about the neurological function because at the time of the orders, he was fine. Maybe he is sick now, he doesn't understand now, and he cannot give the orders now. But previously, he has made the decision that do not treat me. So we have to honor the decision. Okay, guys, agree everyone? No, in that case, see, what are you asking is, can he be delirious due to infection? Yes, he can be delirious, but what understanding of this question gives us that previously he has placed the autonomy that do not treat me. Okay, this is not for do not resuscitation. They are mentioning that some other orders he has placed. Maybe he has mentioned that I don't want the treatment when I'm sick. So at the time of the decision making, they were fine. So we have to respect their decision. But sometimes what happens is that the patient is sick and patient is delirious and patient is not in a mental capacity to give you the answer and they don't have the previous orders as well. In that case, what you want to do is for the best interest of the patient. Doesn't matter if the patient is saying, because those are the delirious patient, okay, acutely brain acutely ill patient. They are saying that I don't want the treatment. They are sick, they are ill, they are delirious, they don't understand what is going on. At the time, you want to do your best practice, you want to provide the treatment. But if you have the previous order for the patient, you have to respect their autonomy. Okay, understand, guys? So in that case, family also doesn't come. Even the family says that treat my dad, treat my spouse. You can't take the orders from the family as well because the patient has previously placed their order, and you have to respect their orders. So you have to honor their decision. And I think have a look on this reference. Whatever we discuss is pretty much there. It's written. It's always written, doctor. Okay. So when the patient is taking the decision, there is in their file. They have to sign the consent. They have to sign everything, and then you can keep on the patient's file. But if they are in a mental capacity and they can deny the treatment, it's you can take again as a verbal as well. Okay. So this is again a very short question. I'm sorry, this is the only question. These type of questions we got in October, but whatever, we can just discuss. So man come from Thailand 5 days ago, come with fever, headache. What will be the diagnosis? Dengue or COVID? That's right. It can be both of them. So that's why I said it can be confusing because the symptoms are very vague. It is fever, it is headache. And during the COVID times, everywhere, everything was COVID. So we didn't understand anything else but the COVID. But if we have more information about the patient sign and symptoms and the good history, then we can make more probable diagnosis. At the moment, looks like it's both. But you can, for example, say dengue more because he's coming from Thailand. Previously, when the COVID was there, we used to give all the diagnosis as COVID, no matter patient is coming from anywhere in the world. It was just COVID. Yeah, it can be anything. Like I'm not saying it's a dengue, it's a COVID, but for the sake of the answer, we put dengue because we don't have any understanding of COVID from this question, as we don't have any sign and symptoms like a flu, shortness of breath, something like that. But it can be anything if you have full history. Because we have had the patients previously, they had no fever, but they were COVID positive. So at the moment it's dengue, but be cautious. Just learn about the full history of the patient and then they give you a diagnosis. Okay, this is again the global dengue fever outbreaks. So I think this is a demographics. If I remember, I put the demographics map here. Yes, so outbreaks, and it shows you where the dengue most commonly the dengue cases are involved and they are presenting in Australia. It's not too much, but just give it a read. Okay. Again, an ethical question. So, family migrated to Australia 1 year ago. Daughter was depressed, but now doing well on fluoxetine. Mother saw ad on TV that it could be addictive. Best management from your end is you will assess the daughter, you will reassure your mother, or you will stop the drug. Okay. So take it this question as the worried mom comes to you and they're concerned about their child because their child is taking some long-term therapy and they saw somewhere that it can be the addiction for their child. So they are coming to you. At the moment, if you are a doctor, what would you do? Because obviously, the any antidepressant is a long term. If you take, it can be addictive, and then she did that. But what you want to do, you want to assess the daughter, or you want to reassure the mother, and you know as a doctor that it can be addictive. As a doctor, your duty of care is that you want to assess your patient. So if the mother is saying it's addictive, it's could be addictive. So you want to assess the daughter. And if everything is going well, the next step is that you can reassure the mother that I have assessed your concern, I have assessed your query, and everything is fine. And then she can continue the therapy or she can continue whatever she is taking. So I think as a doctor, your duty of care is that you can assess your patient and then you can provide your reassurance. If you have never seen the patient, or if you're just you may be verbally maybe listening your story, your patient story from somewhere else, or the mother's story about their child, how can you pass your comment without assessing the patient? So I think it's better if you assess and then you pass on your comment. What do you guys think? Yeah, I feel like because we don't have obviously the full question here, but as a duty of the care that you think. Maybe if I'm doctor, I would assess my patient if my patient's parent is concerned about something, and then I'll pass on my comment that it is reassuring, or they maybe continue with the management, nothing like that. You have to answer the concerns of the worried patients. I think this is the most important thing. Daughter is doing well, but you don't know. You have never seen the daughter. So, for example, if you are passing your concern, you are passing your comment that yes, that's fine, you can just continue the treatment, and you have never seen the patient. And what if it's actually the addiction? So the mother is just saying that my daughter is fine, but I have seen it's an addiction. Would you like to assess the patient, or would you like to just pass the comment that this is fine? I think everything's need the evidence, and unless you see the patient, you cannot pass your comment. So if you're working, for example, in your clinic and somebody comes to you, your normal patient, and yet their daughter or their son is taking some medication, and they're asking that doctor, is it okay? My son or doctor is taking that medication. I feel like it's addictive because I saw the ad on TV. So what is your duty of care? That you will just say, no, no, that's fine. Or you would ask the patient that bring your daughter or son, I would just want to assess them and then I can pass my comment. You are right, Dr. Fezia. If you are referring to John Mutta, I'm not denying the fact. I'm just answering this question that the patient is taking the patient. I'm not sure the patient how much the patient is, how long the patient is taking their antidepressants for. So they migrated to Australia 1 year ago, but we don't know the history back then. Okay. So this is again depends when the real life question comes to you guys. So maybe we cannot just rely on the answers. Maybe I'm wrong. Maybe you are wrong. Maybe the whole idea of this conversation is you try to understand the question. Okay. I think we can do next question, and then we can just I can just answer a few of your queries. So this 23-year-old girl come in Saturday morning with malaise, fever, body ache. Last night had a party and took alcohol with the party drug. What is the cause behind her presentation? Alcohol withdrawal, party drug, infectious mononucleosis. Okay, sorry guys. So most of them answers B. Okay, what makes you think it's a party drug, and what party drug was that? So those you understand if it's a party drug, what do you think? What party drug it could be? And can some party drug give the fever or malaise after last night? Because she had the party last night, possibly Friday night. She's presenting Saturday morning. Okay, MDMAs, ecstasies, amphetamines, all of them, I agree. But the side effects they give or the effects they give, we all understand the euphoria and the, vasodilatation, those sort of things like anxiety, sweating, heightened of the senses, everything, large pupils. The patient comes in with the similar presentation to you, but with the malaise, fever, and body ache, I don't think that the patient is having the drug last night and they showed you with this presentation. The presentation would be quite different if the patient has taken the party drug. So they can come with the tiredness because they had all the euphoria and all the energy wasted last night with the drugs. But then in the morning, they come with the tiredness to you. But again, they're talking about the fever. Okay, so if you have heard about the infectious mononucleosis, the kissing disease, it can happen in the parties. It can spread with sharing the glasses even. It can happen with the, kissing on their own. We can understand that. And it can happen with the sharing of the utensils, sharing of the glasses, the wine glasses they take. So basically, they are just giving you the clue about the party drug here to make you just distract from the actual thing. But yes, the infectious mononucleosis can present the next day. Next day. Alcohol withdrawal, she cannot present with the alcohol withdrawal with the fever. So they are presenting with fever. If it was just the malaise and the body ache, maybe it could be the party drug she has taken last night, but now she's coming with the fever. So the party drug cannot give you a fever unless the infection is present already in her body. She was sick already. So we don't have the history about that. The only thing is giving the clue about any infection here is that she has a fever. And we understand that anything cocaine, I don't think so. Can cocaine brings about the fever? And if she has the fever, it would have been last night as well. So this morning she's coming with the fever. All the things happened last night. So she had all the euphoria, all the presentations of any ecstasy or amphetamines last night. She's coming with the fever this morning to you. Fever is a thing which is present with the infectious mononucleosis because this is infection. Okay, so cervical lymphadenopathy can take time to develop, but fever can present early. Right? I can show you maybe in this reference. Have a look on this one. So we can just maybe wind up for tonight. Rash can comes on later, doctor. Okay, rash can comes on later. Cervical lymphadenopathy can comes on later. So EBV spreads from person to person with the saliva, contact, kissing, sharing utensils, drinks, coughing, sneezing, anywhere. So she might be having an area where the close premises was there. She was sharing the drinks, she was sharing the cutlery with someone, and she might get the infection. Fever is the first sign that is present. Why we call it the glandular fever? Because of the gland, cervical lymphadenopathy. So cervical lymphadenopathy can appear later, but fever can be the present first sign. Rash can also appear later. But cervical lymphadenopathy, to leave about cervical lymphadenopathy, you cannot deny the fact that your patient is coming with the fever. I can maybe show you one more reference. So this was a general one. And then have a look on this one, a more precise one. This one. Okay, if you have a look on here, uh, the EBV or Epstein-Barr virus comes in acute phase and then the phase which is ongoing. So acute illness phase is revealing a raised white cell count, which is obviously increased lymphocytes. And then the lymphocytosis is peaking in the second or third week of the illness. So with the acute phase, the patient still have the fever, but if you have a look on the test, you might not look the WBC is increased in the first week. But the patient is harboring the EBV in their pharynx because it's spreading from the pharynx and they harbor in the pharynx. And then afterwards, the rash, the lymphadenopathy can appear. It can happen. And again, we don't have the history here. The full history is always missing. So if I go back to this case again, the patient coming Saturday morning with the malaise, fever, body ache. She might have the encounter with someone who had the virus, but obviously she's having the virus inside her body. If you take the test for her now, you will not see WBCs increase. She's already having a fever. That means she's infected, but it takes time for the antibodies or monocytes to show up in the lymphocyte in the blood film. Incubation period is, I think it's more than a 1 week time. Incubation period when the patient is presenting, clinical picture takes, I think, 1 week time, if I'm not wrong, in terms of pathology, but the patient can present with signs and symptoms as early as they can. Oh, I think we are above the time already. So maybe I can just answer your few questions. So, guys, if somebody wants to leave, you are free to go. We have just finished up tonight's class. I'm just answering few questions and they'll be finishing up. Serotonin syndrome, Dr. Hanifa, again a different picture. See, so serotonin picture don't present with this type of serotonin. I think if you recall about the serotonin patient, you can just imagine about how high they are, how hyperthermic they are. They're very hot. I think they call it the hot as bone and brittle, something like that is the acronym for that. So serotonin picture is similarly not very similar to this picture which is shown. And obviously the history is not very much present here. So it's quite vague question to be discussed, to be honest. But I don't understand it's a party drug. If it's a party drug, the patient had the symptoms very simultaneously and very acutely. The patient is coming after a night. Now, see, if it was any viral infection, but not infectious mononucleosis, my first instance will be the viral infection because we can get the virus very easily from the closed spaces. So it can be any virus infection. I won't give for the infectious mononucleosis specifically for this question, but any viral infection can happen in the closed premises. The patient can present after a wedding, after a closed premises company or something like that, and they can present with the viral infection next day. There's a whole party drug, Doctor. Pez, whole party. So MDMAs, cocaines, amphetamines. I think many party drugs are there. You can maybe have a look on the Google, and maybe I can share on the portal as well as a reference if you want. All right, guys. With that, maybe we can just wind up tonight's session. The management is symptomatic. Yes, at the moment is symptomatic because you don't know what is going on. So at the moment is symptomatic. Just painkillers, rest, and fluid, and we see how we go from there. Okay. Okay. Thank you, guys. Thank you for staying back, and we see you maybe next time. Thank you. Good night.